Good afternoon, everybody. Welcome. Excited for another awesome webinar. We are at the pleasure of having Dr. Dan Trifiletti join us. Our team will introduce him shortly here. Another webinar that will focus on some of the aspects of radiosurgery and radiotherapy. I want to thank our tumor section subcommittee members, Yashua Ashkenazi, Mahwade Ashish Shah, and Ankush Chandra, for organizing this, and of course the NS who's been supporting our educational outreach and webinars. These are all recorded on our website. Please visit the website and you can go over this talk whenever you'd like. Thank you very much. And Dan, looking forward to your talk.
Yeah, thank you. So today we'll have Dr. Trifiletti from the Mayo Clinic in Jacksonville. And Dr. Trifiletti is an internationally well-known radiation oncologist. His work includes numerous clinical trials looking at radiation, surgery, and drug therapies in the treatment of tumors. He's published extensively, and he's going to present a very nice talk about what the neurosurgeon needs to know, which hopefully will help everyone make decisions for patients, as radiation is such a critical and integral part of our practice. I won't take any more of your time. Please, Dan, go ahead.
Thank you. Thanks, everybody, for having me. It's an honor and pleasure to be speaking with everybody. Here are my disclosures listed on this slide. We're going to talk a little bit about radiation machines and then some kind of high-value stuff. I want to be practical and broadly applicable to the audience, knowing that there are senior members and trainees involved, and then brain tumors people, but also spine people. A quick word about radiation's mechanism of action. The important thing about this is that it creates double-stranded DNA breaks in the tumor cells. How the energy gets there can be through particles or through photon energy packets. They can interact directly on the DNA or through other pathways. But when the tumor cell DNA breaks, it has a difficulty repairing it. And so it sort of neuters the tumor cell. When it goes on to try to grow, it dies. The tumor cell can repair that damage. It could do that successfully or unsuccessfully. But a principle about this is that normal body cells, your normal skin and neural cells or whatever, are able to repair the damage more effectively than tumor cells. In the same way that when you get sun exposure, your skin peels, that's your dermis healing and repairing and maybe killing off dead dermal cells and peeling and then repairing itself. So the idea here is that while radiation can be focused in terms of dose locally, it also has this separate thing. It's different than a scalpel per se, because in a surgery, what you take out comes out and what you leave behind stays behind. With radiation, you can treat something that's normal and keep its function there, which is something that I think as radiation oncologists, we think a lot more about than perhaps radiosurgery. It can be an ablative technique, which is more in the radiosurgery world, but it can also kind of be more like an oven, like a broader, gentler radiation that works slower over time to a larger area. That's a really important principle in radiation oncology that I think it should be emphasized among the neurosurgeons. Part of the reason why this is so confusing is that there's all these different machines and direct to patient or direct to physician marketing. And when you include billing terms in there, it can become very confusing. The important part about this is that all modern radiation technologies are going to have similar goals, and that is going to be to maximize patient comfort and also minimize treatment duration and focus the radiation as much as possible. Like Sel said, that there can be no machine that's too precise, and that's sort of true across the field. The biggest difference, I think, practically speaking, is that like the Gamma knife can only hold the patient's head in the machine. So really only like head and upper C-spine tumors could be treated in a Gamma knife. Whereas other machines, let's say Linac-based IMRT or CyberKnife treatments, could treat anywhere in the body. So for a radiation oncology practice that's treating a lot of prostates or breast cancers or whatever, those may offer other advantages. Or in your field, spine tumors could be treated with the machines on the right. Proton beam radiation is sort of a similar vibe, although the idea is that it can focus the radiation a little bit better. That could be done in short treatments or long treatments. This is more about dose conformality. And then there's new and emerging machines coming out every day, and it can be very overwhelming. But the marketing pitch for all these companies is more precision, more patient comfort. As far as precision goes, we look at these, how precise the treatment is with dose maps. On the top left is 3D conformal radiotherapy. This is a technology that would have been very common in the early 2000s that gave way to intensity modulated radiotherapy, which is in the top right, or proton beam radiotherapy on the bottom. These dose maps show the intensity of the radiation as it spreads across the brain. As you can see, we've had efforts to make things more and more conformal. A challenge with this technology over time is understanding where we want to bend and shape radiation out of, what parts of the brain are, eloquent versus non-eloquent. It's sort of like that, but it's different because radiation doesn't just like kill the eloquent brain. It can handle it. It's more about kind of global radiation, maybe to the supplementary motor cortex. That matters a lot, or the perihippocampal gyrus. There's parts of the brain that we don't really know how they interact with radiation well enough to know how to restrict dose and maximize patient outcomes. So this is kind of an emerging area for the field. This is an important topic on this slide, but can be a little challenging. The idea is that everything I've talked about so far is about conformality of dose. Independent from that is this dose fractionation effect. So you can have a really tight radiation plan and give the radiation all at once, or have a tight radiation plan that does the radiation very slowly over time. This is an important principle in radiation oncology, and it's a parallel to antibiotic therapy. You might want to give an antibiotic taken daily every day for a week, and that does not hurt the patient and it kills the infection. But if you took the whole pill of antibiotics in a day, that would cause toxicity for the patient. And this is the same sort of idea. You can give all of the radiation very intensely and quickly. That's more aggressive. Or you can give it slower and gentler, which would be more appropriate for a larger radiation field. And the rationale to do one or the other can depend on the type of tumor it is and how much it's infiltrating the normal tissue, what the treatment volume is, et cetera. An important part about this that I think is maybe lost on a lot of neurosurgeons is that in the neuro-oncology field, radiation is really used for patients with incurable diseases, including brain metastasis or glioblastoma or high-grade gliomas. In the setting of benign tumors like meningiomas, et cetera, the treatment can shrink the tumor, but it's more about a stabilizing effect. That is a little different in our field. In most other extracranial disease sites, radiation is a curative treatment and a well-established curative treatment. So patients with advanced head and neck or pharyngeal carcinomas, let's say, can be cured with relatively low-dose radiation alone, or prostate cancers or lung cancers or whatever. So that's just an important point. The treatment itself kills the cancer. It's not just about palliation. Just to kind of go through some clinically relevant disease topics in terms of brain metastasis. This is a picture of me when I was 25 years old doing brain surgery. That's a joke. That's AI. So we kind of group brain metastasis into limited disease or extensive disease. And in general, the kind of thinking is that if you have less tumors with more mass effect, you should be getting radiosurgery with or without surgery if it's appropriate. More extensive disease should be taking hospice. And then in the middle is this whole brain radiotherapy group. Over time, this has been well established, although the barriers have been shifting some. Just to highlight one such study, this was a study that evaluated the impact of whole brain radiotherapy in patients with limited disease. It showed that elsewhere intracranial progression was improved with whole brain radiotherapy because you're treating the whole brain, but cognition was worsened in patients who take whole brain radiation. This has been measured with clinically relevant testing, but also radiologic endpoints like this. Periventricular white matter changes and difficulty with short-term memory, Hopkins verbal learning scores. In the postoperative setting, so this is after a gross total resection, there's also evidence to support adjuvant radiosurgery. In this study from MD Anderson, which was a prospective randomized study, radiosurgery to the postoperative cavity improved local tumor control. These sorts of things have really shifted to make more patients eligible for radiosurgery, and we want to do it more, maybe more METs or bigger METs to reduce toxicity for patients. On the other end of things, this is an important trial, the Quartz trial. This took patients with non-small cell lung cancer brain metastasis that were, not amenable to radiosurgery. All patients took steroid therapy, and the randomization was to take whole brain radiotherapy or not. Whole brain radiation did not impact patient overall survival. In our training, we say, well, yeah, brain met trials typically don't impact overall survival, but they looked better. preventing seizures or hospital admissions is a meaningful endpoint for patients, and brain radiation controls the intracranial disease, which improves their outcomes. In this study, that was not the case. Just quality of life between arms were the same in either group. So that really makes me think like, well, maybe for patients who have more advanced disease, that we should be not treating them with radiotherapy and offering more hospice for those patients. This is sort of squeeze the whole brain radiotherapy group where we recommend it. And nationally speaking, we don't really know when to do it. A quick word about this that's different is there are some tumor histologies which are considered very radiation sensitive that have a high propensity for brain metastases, and we commonly do whole brain radiotherapy. They include, generally speaking, small cell lung cancer, which is different than non-small cell lung cancer. Small cell lung cancer is considered to be very radiation sensitive, and we would be more likely to do whole brain radiotherapy in general. Lymphomas, germ cell tumors, those sorts of things. But whole brain radiotherapy strikes back, and in efforts to improve the effectiveness of whole brain radiotherapy and reduce the toxicity, advancements in radiotherapy technique have offered some opportunity for that. The best example of that, I think, is whole brain radiotherapy with hippocampal avoidance. The rationale here is that the hippocampus is important in memory, and memory is a toxicity from whole brain radiotherapy. Maybe we can just kind of scoop the radiation out of the center. And note that this would only be possible with advanced radiation techniques. So this is sort of a more modern technology. It did show some improvement in neurocognitive failure as measured in this large NRG study. So it may be that in the future we use whole brain radiotherapy. This is still kind of figuring out how things shape out in terms of number of brain mets or location or patient factors that might influence these decisions. Another thing that I think is important for this group to understand is radionecrosis. This is a very frustrating and confusing topic for everyone. One of the main reasons why it's confusing is that we don't have the same definition for it. Radiation kills tumor cells, but it kills them. It doesn't like just melt them away. And as the tumor cell dies, it can create peritumoral inflammation and increased blood flow, peritumoral edema, which can increase contrast enhancement and have mass effect. That's a good thing. We want to kill the tumor. We don't want it to overreact, though. That could create symptoms and be managed with medical therapy or surgical intervention. Separate from that, the radiation could just kill the normal brain and create a problem. That would be real radionecrosis. You have normal brain that dies from radiation. Separate from that, you may have tumor cells that are destined to die, sort of senescent tumor cells that would be considered alive by histopathologic evaluation, even though they're just going to age out over time. And so distinguishing these categories based on MRI is basically impossible. Distinguishing them based even on histopathologic evaluation, which we consider to be the gold standard. If the pathologist tells me that there's living tumor cells, I don't really know what that means. That might mean that they're just going to sit there and die, or it might mean that they're going to go on to propagate and create a problem for the patient. In general, the management's listed here in sort of an order of escalating intervention. Many times these patients can be just observed with no therapy, steroid therapy for symptoms, or bevacizumab. Resection should be considered mainly based on patient symptoms, and if it's not an operable location, lit therapy is a good option. The ISRS, International Stereotactic Radiosurgery Society, recently put together a guideline for this, which is in the Red Journal, the International Journal of Radiation Oncology and Biology and Physics, which is the RadOnc journal, which you can go to there, but it's basically what I just said. There's been a lot of efforts to improve the therapeutic ratio in patients with brain tumors. One method is with conformality, which I've been discussing. A second method is with fractionation. So there's really no reason why we can't treat a focused radiation field, but do it gently over time, like I was saying, which is this the rationale for fractionation. This is sort of an emerging area that people are doing, and I expect that all of your centers, the radiation oncologists, are kind of doing this trying to figure out when to do it. This was a study out of Italy that took patients with brain mets that were over 2 centimeters. These are intact tumors, and they showed by breaking the radiation into smaller pieces, they had improved tumor control. There's also evidence that this could reduce side effects from radiosurgery. A note about this, you'll see that the dose and fractionation, let's say it was 18 gray in 1 fraction versus 27 gray in 3 fractions. This is a common thing where the doses are not the same. you don't just do like 30 gray in 1 fraction or 30 gray in 3 fractions, because the dose per fraction affects the biology. This leads to a lot of confusion among non-radiation oncologists to know how to compare doses. And honestly, I don't even know that you can. It's pretty hard to learn it. We have like calculators that help us guide us, and a lot of this is from just a lot of utility doing it and talking about it. You kind of get a handle for the types of doses that would be comparable. I have a table at the end, which I think will be helpful to guide this group in general. This is a patient with a occipital brain metastasis. You can see it's sort of dural based and on the sinus there. This case was resected, as you can see on the right. That's the postoperative scan. And I bring it up to kind of highlight the difficulty in treating patients with radiosurgery after resection. The red arrow there points to kind of the deep edge of the surgical cavity, which it would be believable there could be tumor left behind. It was kind of next to the tumor. It's on the deep edge of the surgical field. I think that should probably be covered with radiation. But what about the sinus? The sinus was not tumor before, it was left behind, but is it at risk for tumor recurrence? Should that be included? Can you distinguish the tumor bed from the sinus itself? What about way over here? This is clearly outside of where the original tumor was, but it's considered part of the surgical bed. All of these areas would be included in like the current expert opinion for radiosurgery to the postoperative cavity, which just emphasizes the idea that we really have a lot to learn about what to cover and how. One opportunity to minimize the uncertainty associated with postoperative radiation is to treat preoperatively. So this is a patient with a sarcoma of the right occipital lobe here. The yellow in the middle shows a preoperative radiation volume. You can see the contrast, you can contour on the contrast. On the right there is a postoperative scan. The blue again shows the preoperative radiosurgery volume. The green demonstrates the postoperative consensus contours. So you can see that the radiation field is more easily defined and focused in the preoperative setting, and also the vast majority of the highly irradiated tumor is resected. Sort of by definition, in the postoperative setting after a grossular resection, you're kind of purposefully treating normal brain to try to sterilize that rind of tumor cavity and reduce tumor recurrence. So this is an emerging area. There's lots of potential benefits of preoperative radiosurgery in terms of radiation sensitivity to the intact tumor as opposed to the hypoxic tumor microenvironment after resection, and several other components. This is being studied in a prospective randomized study, which we're a part of. This is maybe 80% done through accrual. So it's marching along. Hopefully we'll have an answer to the preoperative versus postoperative radiosurgery question in the coming years. Another quick word about radiation, which I think it would be kind of interesting for this group, is that patients with leptomeningeal carcinomatosis have a challenge in that there's limited effective therapies. In the neurosurgery world, I assume you're not having a whole lot to do with these patients besides placing Omayos and maybe a few other things. Limited intracranial activity of systemic agents. This was a prospective randomized study that was done in New York, which compared craniospinal irradiation done with proton beam therapy compared to just treating the symptomatic disease. So the standard of care for patients with leptomeningeal disease is just to treat the symptomatic stuff. You have headache and vision changes, we'll do whole brain radiation. You have a lumbosacral radiculopathy, we can treat that palliatively. But we don't really treat the whole compartment. That's a little different than some other diseases where, let's say, there's studies in ovarian cancer to treat the entire abdomen and pelvis with prophylactic abdominal radiation to prevent peritoneal carcinomatosis or mesothelioma. The lung fields can be very large, or lymphomas, etc. Historically, we don't really do it in leptomeningeal disease. Part of the reason is because it exposes a lot of the bone marrow to irradiation and causes pancytopenias, which limits systemic therapies. Proton radiotherapy can limit that effect. And so the study here was investigating if CSI would help these patients if done with protons. It did reduce the rate of intracranial tumor progression, which is that curve A. But interestingly, it also improved overall survival for patients. That's on the far right. Let's see, this is 63 patients. It had limited histologies here, but it was a randomized prospective study. So this is sort of an interesting emerging area. This is done slowly, because it's such a large field, like we've been talking about. It's sort of like a whole brain radiotherapy dose, but given to the whole brain and thecal sac. This has led to the launch of this study, which just opened, an NRG study, which is randomizing between the same cohorts, proton craniospinal radiation and involved field radiotherapy, to hopefully answer the question on the best way to treat these patients. Some other stuff about brain mets, which I feel like is always lost in all of these studies, like the number of brain mets stuff can be kind of frustrating because it's a lot different than the patient you're talking to. There's so much more to talk about with patient decision making, patients with brain metastases. Shown here is a patient with a big brainstem tumor. Obviously, you would treat that differently than a anterior right frontal tumor, totally differently. And so these things may be lost in some of these studies, and I think is just important to bring up. The transition to high-grade glioma, here's a patient with a big high-grade glioma. The Stoop trial, this group is familiar with, that validated temozolomide and also 60 gray and 30 fractions as the backbone for therapy, with a modest improvement in survival with the addition of temozolomide. The Perry study is one that this group may have heard about some. This was another large randomized study published in the New England Journal. Similar design to the Stoops trial. It was radiation versus radiation plus temozolomide, and temozolomide improved survival. The difference with this study is that it had an abbreviated radiotherapy course. So this is 40 gray and 15 fractions. Similar radiation treatment volumes in general, which we'll talk about a little bit, but this is something we would term moderate hypofractionation. So regular fractionation would be 30 fractions, 60 gray and 30 fractions, and we'll moderately reduce that to 15. It's not considered extreme, down to like 1 or 2 or 3 treatments. It's still sort of gentle. But it's more convenient for patients. This trial showed, and along with some others, that this 15 fraction schedule is appropriate, particularly for patients who are over 65 years old or maybe don't have a great performance status, and this would be considered part of the standard of care. So in patients that you guys are operating on, in the postoperative period, they may take 15 fractions or may take 30 fractions, depending on their age and performance status and discussion of goals of care and that sort of things. This is an emerging area with plenty of opportunity for improvement as well. A word about GBM margins. So this is different than radiosurgery and kind of emphasizes the idea. On the far left is a T1 post-contrast image that delineates the tumor cavity, and then that's expanded. That's the red cavity. So we purposefully treat the adjacent normal brain, as that's the highest area for tumor recurrence. It typically includes peritumoral edema. And then we put a little bit of cushion on that to account for patient setup uncertainty or movement during the treatment. On the right, 2 images demonstrate where this patient recurred with the radiotherapy fields overlap. So you can see that despite these sorts of fields that are considered pretty generous, I think, from a neurosurgery perspective, patients still, the most common location for tumor progression is in that high-dose radiation field. There's been some randomized trials that have compared different radiation expansions or different doses with generally similar outcomes. But no, this is like maybe a centimeter or 2, just to kind of put it in perspective. And then we restrict that to natural barriers to tumor spread, such as the falx or the skull or the tentorium, that sort of thing. And then just a quick word about vestibular schwannoma, which you guys all know about, sort of like meningioma, the skull base, kind of treated, monitor it, or resect it, or give radiosurgery. For very large tumors, maybe fractionated radiotherapy would be recommended. But I want to highlight the VREX trial, which is not a resection trial, but is a randomized trial that recently published in this space. This is 100 patients with small to medium vestibular schwannoma, defined as 0 to 2 centimeters. They were randomized to take radiosurgery up front or just closely monitor them with future scans. And the primary outcome was tumor volume change. Tumor volume was reduced or grew less compared to nothing. They met the primary endpoint. And of note, a lot of the patients, 42% of the patients who were initially observed ultimately got salvage radiosurgery for tumor progression, and a few got resection. But I think an important part about this study are the subsequent curves. So the top left here shows tumor volume that was improved with radiosurgery. That was a primary outcome. But basically all of the other stuff was the same. And so this is a common thing I hear from otolaryngologists or neurosurgeons, that radiation will cause hearing loss. And of course it will, but also doing nothing will. These are the pure tone averages over time, demonstrating kind of a slow collapse of hearing over years. which is basically identical compared to nothing. Word recognition score similarly. Equilibrium was maybe a little worse with radiation, but not really. It's kind of how I would describe that. And this is the quality of life on an acoustic neuroma specific test, which demonstrates no difference between groups. So I think overall, this is kind of worthwhile for this group to take a look at, because it shows that radiosurgery is sort of considered a gentle, non-invasive treatment in a sense, and that it's not causing these abrupt changes, but it does result in tumor control. Of course, there's risks to radiosurgery in some patients. This is probably a high-yield slide, particularly for the trainees. In general, for patients with brain tumors treated with radiation, you want to be thinking about prophylactic steroids, of course, and then resection for release of mass effect. The two main benefits of surgery, brain surgery in general, in my mind, are immediate release of mass effect, which is obviously important in many patients, and histopathologic diagnosis. Those are two things that radiation would never offer: pathologic evaluation and immediate release of mass effect. So that's something to always be considering. This shows kind of like how I think about tumor diameter, its size, and then for small tumors, they can be treated in a single treatment with sort of like 20 gray-ish malignant doses and maybe 12 gray-ish benign doses, with some flexibility based on experience or adjacent organs at risk. If it's getting bigger, 2 or 3 centimeters, I'm more likely to fractionate. That's a common thing among radiation oncologists, that we kind of have a lower threshold to break treatments up, whereas maybe neurosurgeons performing radiosurgery would be more comfortable treating bigger tumors with single treatments. For really big stuff or stuff adjacent to critical organs, fractionate more. And then if it's really big, we might be talking about whole brain radiation. In the long course radiation setting, which is GBM, for malignant tumors, we're treating this like 60 gray-ish, maybe 54 gray for atypical meningiomas, or if the tumor is very big. For more benign tumors like large meningiomas or low-grade gliomas, we would be treating more in the 45 to 54 gray range. So just kind of like a general sense of the sorts of numbers that you're going to commonly see in clinic. That's all I have, but I'm happy to answer questions.
This was great. Really, I mean, you went through most of the things that we encounter in clinic and that are really critical. If I can ask, what is you guys practice at the Mayo Clinic for patients with large volume and multiple metastases, 10 plus, 15 plus, even 20 patients? Many of those don't want to get whole brain radiotherapy. I would like to know if you guys typically do, single fraction gamma knife, or are you doing Linac-based, fractionated regimens for those patients? If you mind saying some of
No, yeah, great question. So I'd say that this is where all those other stuff is super important, but a younger patient with the newer diagnosis and better performance status and more systemic therapies as an option, it's going to lean me towards radiosurgery compared to the converse. I don't have a limit in my mind on the number of brain metastases that I would think about that, or even the volume. If they start to get big, it starts to make me think, I'm going to create a problem here. If they have many 2-centimeter tumors throughout their brain, and I am too aggressive, I'm probably going to just cause a ton of edema, and then they're going to get readmitted, and the neurosurgeon's not even going to know what to resect because everything's bigger. And so that can be a real challenge about kind of tipping them over the edge. And for that reason, longer course radiation may be in the patient's best interest. But regarding technique, we have a gamma knife and a true beam. And I would say that either one would be fine. The challenge with gamma knife for many tumors or tumors with large volume is that treatment time can be very long. So depending on the patient's ability to tolerate that could influence my decision. Linac-based radiosurgery systems are typically faster with perhaps some loss of conformality. The comparisons between those techniques have not been clear. I think most of the evidence supports that they have similar outcomes, but it does depend a little bit on the location. Let's say a brainstem tumor, I might be a little more concerned about specifically. But I would say that patient, I can and do treat those patients with radiosurgery, although I think it's worth an honest conversation because they are certainly going to develop elsewhere intracranial tumors in short order with local therapy. There's a clear benefit to whole brain radiation in total tumor control in the brain. And I think that should be discussed well with the patient.
Hey, Dan,
Thank you.
really nice talk. Thank you again. What are you guys doing for adaptive radiosurgery? That's something since I've gotten back to Pittsburgh, we're doing more and more of. And I think particularly for the elderly population, building off Joshua's question for the larger Mets, I've learned that approach, does spare a lot of these patients from going to the OR if they're 78, 76, with these big Mets. What are your thoughts?
Well, so it's a good question. Adaptive in the rad-onc world means something a little different than I think your question is, but I just want to mention. So there are radiation systems that allow for real-time adjustment of the radiotherapy plan, meaning let's say you have a pancreas tumor and you're coming for 30 treatments. We could maybe get a CT scan or an MRI scan while you're laying there and just create a new plan immediately and then turn the beam on. And we create a new plan every day. For some tumors that respond a lot during the radiation treatment, let's say for like a big orange in their neck, and it's shrinking over every day, that you need to be creating a new plan really quickly. That, in my mind, that's really what adaptive means. In the neuro-oncology world, it sort of means more like maybe a staged approach separated by a few weeks, which I think is what you're getting at, which is kind of like a Cleveland Clinic strategy. Yeah.
Yeah. Like a month.
And in general, I think the field is kind of separated into more staged kind of things where you give a treatment and then wait maybe a month and then give another treatment, or fractionation where you're breaking it up in smaller pieces, but giving it over a specific time. I think either one is fine. Honestly, staged has been around longer, mainly because of limitations in technology. And that sounds pretty appealing. There's another, UT Southwestern has this Pulsar clinical trial project, which is doing similar stuff in extracranial tumors with promising results. I don't think that there is a real difference. I think the advantage of staged radiosurgery is mainly one that you kind of like see how the patient does. You can give them 12 gray or something and then wait a month. And if they come back and have 50 tumors in their brain, then it kind of like answers the question for you, or they just get real sick from their lung disease or something. And then you didn't really hurt them, but you kind of shrunk things a little bit. You thread the needle there, as opposed to just giving a bunch of radiation up front and hoping you didn't give too much. But another bit about this real quick is that the tumor cavity changes quickly, particularly in the postoperative setting. And so getting fresh MRIs is really important. And if you think that the tumor could respond because of tumor histology or whatever, that if you're fractionating even over a week, there can be pretty dramatic changes in tumor geometry, and a planned interim MRI has a lot of value. That sort of like real-time adjustment stuff is much easier on some radiation platforms than on others. And so there's like a lot of moving parts here, and it's really institutionally dependent on the type of technology you have and the kind of your ethos, if you're more of a fractionated person or more of a staged person.
That was a great talk. Can you comment a little more on, a lot of patients are now on checkpoint inhibitors, and do you do any dose adjustment with your SRS if they're on checkpoint inhibitors, or is that something not necessary? Yeah, if you can elaborate a little.
Yeah, great question. Controversial area. So originally there were some reports that peritumoral edema and radiation necrosis was increased in patients taking checkpoint inhibitors if they take it in that or about 2 weeks before or after a radiosurgery. There's also evidence that it may make it more effective. And so that's kind of the challenge. We published a large meta-analysis on this and showed that there really wasn't an increased risk of toxicity with checkpoint inhibition. I don't really think about it that much. I think I probably wouldn't do it the same day. And then if you can separate it by a week or so, I think that's okay. But I'm less concerned about single agent checkpoint inhibition like Keytruda or nivolumab. For patients with melanoma who take ipilimumab, I think the risk is higher. That's a little bit more of a toxic drug. And then for traditionally cytotoxic chemotherapies like cisplatin and etoposide or something, I would want to separate it a little bit more. I think if the radiation's first, it's better than if the radiation's second. But I try to get like a week out, something like that. But in the end, you kind of want to just get in and out with the radiation and then let them get back on drug therapy, but it does require some coordination. I know I didn't really answer your question, I'm sorry, but it kind of gives the
And
vibe.
another on the controversial side, in which scenarios we get patients that have EGFR mutant lung cancer or melanoma meds that are going to be put on immunotherapy. And as you know, some of these patients can have CNS responses from these targeted therapies. In which situations would you say that you would hold radiation and let the systemic agents do their job and then potentially reassess and treat? Obviously, you know, for smaller lesions, radiosurgery response rates are 99+%, right? Or more, even 100%, some of Conciopa's work, but anything less than a centimeter. So you would say, well, if radiosurgery works so well, why would you not do it? And I just like to know what are your thoughts on that, because this is something that is becoming very popular.
Yeah, it's a great question. And my opinion is that EGFR inhibitors, new EGFR inhibitors and ALK inhibitors are good. And for patients with with small volume disease, where you think it could probably grow like double in size and the patient would be okay, like worst case scenario, I think and they have not received these agents yet. That's a prototypic patient to say, hey, let's try the drug therapy, repeat a scan at a short interval, maybe a month, and make sure that we're headed in the right direction. That patient will probably ultimately get brain radiation. But I just don't think you need to do it up front. And the real example where it's appealing is where you feel like you need to give whole brain radiation. So let's say they have like 20 or 30 small teeny mets. That's a great patient where you'd say, hey, let's try drug and then see what happens. And maybe we can kind of get out of this bind. Another option, which is unorthodox, is to select high risk brain metastasis. This is a trial that we're opening where we're sort of choosing the ones that we're scared of, ineloquent brain or of larger size with peritumoral edema, those sorts of things. Treat those and watch the other ones and see if drug therapy works in the other ones. Checkpoint inhibitors, traditionally cytotoxic chemotherapies, etc., have less robust intracranial activity outcomes. And so it depends on the agent and what the alternatives are and stuff, but it kind of paints a picture there that like, if it's just one small met, you're right, local control is super high. But I'm thinking in my head, if it doubles in volume, it's still really high. It's like a 2 millimeter met. If it goes to 4 millimeters, that's not really a risk. Of course, the patient needs to understand this and the risk of intratumoral hemorrhage and that sort of thing in the interval.
Thank you.
And thank you for the wonderful talk. I had a question with regards to preoperative SRS for brain mets. What are your thoughts about that? And what is a good selection criteria you've seen in practice?
So I'm a big fan of it, but we are enrolling a lot of these patients on trials. So there are several national and institutional clinical trials looking at preoperative radiosurgery for brain mets. My opinion, not knowing, is that I think it's pretty cool, and I'm hopeful it will be helpful. I don't think it's going to be like solve everybody's problems or anything, but there are a lot of potential advantages to it. The biggest challenge on the radonc side is that we're just like not built like the neurosurgery department is. So you guys have like somebody who's like always operating on call and like ready to do whatever, stroke or whatever, and you just like have an OR open to do this stuff. So we don't have that. And so, and it takes a little while to put together a radiation plan. Like it typically takes like 2 weeks, which is really not appropriate at all for the patient that you're describing. So kind of like the biggest challenge on the radonc side is like setting up a system that can handle these like emergent, urgent, do it now kind of patients. And then like I'm trying to coordinate with you too. And you say, I only operate on Tuesdays. And I'm like, trying to fix it and to work with all this. So that's an issue that we have solved at my center, but it doesn't help you guys at all. Everybody has to kind of do their own thing. In terms of selection criteria, I think that any patient where you really think it's a brain met, that's probably the hardest part. If they don't have a diagnosis and you don't want to treat a GBM or an abscess or something, you want to feel good about it being a brain met. That's probably the biggest challenge. And then coordination of schedules and like the radonc you got to like it's just another team member to have to kind of like get in and another sort of preoperative clearance check to do to figure out that coordination is really significant. But I think anybody who's eligible for a resection would be a potentially good candidate for radiosurgery. I think if you're going to give whole brain, then I don't think that preoperative treatment makes a lot of sense. But a lot of the benefits of preoperative radiation would be lost. So if you're operating on a patient with leptomeningeal disease or something, I don't really think that would make sense. But I think, you know, most of the trials that are open are going to be enrolling patients with 1 to 4 brain mets, or maybe 1 to 10 brain mets with a previous pathologic confirmation of a cancer. You'd want to be avoiding small cell and germ cell tumors, like I mentioned. But yeah.
Thank you.
We actually published a phase 2 of preoperative SRS, which we also did is genomic analysis on the tumor that we resected. And the most interesting finding we found is that the genomic signature of LINAC versus Gamma knife is very different.
Yeah, that's very interesting, because the dose deposition is going to be a lot different between the technologies. Gamma knife is considered a little more heterogeneous, so the centers of the tumors are going to get much hotter. Much hotter means twice as much radiation dose. But you know, the rationale is, well, I don't really care. It's tumor. It can get 1 million gray. That's fine, as long as it's not the normal brain. But certainly that would be, I would expect that to be creating differences in DNA profiles. But it's super interesting to see that.
I had a quick question. I know we're running over time. Great talk, by the way. I just had a question. You know, I'm here in Miami. You know, we see a lot of patients with radiation necrosis, you know, coming in from the community. And I just kind of wanted to know what your treatment paradigm was, kind of starting from the beginning. We started using Boswellia a little bit here. And I kind of want to know, you know, at Mayo, what's your treatment paradigm for patients with radiation necrosis? And, you know, when do you push the trigger to go to the OR?
Yeah, so good question. The paradigm sort of like do nothing, steroids, and then if that's not working, then decide what to do next. The medical route is going to take you down like Avastin, and would affect their eligibility for a resection, because you don't want to give them Avastin and then operate right then. So I think if the steroids aren't working, then I'm like texting people and have the talk.
You guys don't use any vitamin E, Boswellia, or anything in the middle?
So yeah, not really. I think Boswellia was validated in a recent publication through Ohio State, and I think that it's a good option, and I think it's helpful. I don't think it would replace a real intervention, you know, surgery or lit or something. I kind of consider it to be like steroids plus, or maybe like steroid in a patient with medical issues from steroids and whatever, myopathy or something, and can't take the steroids. I think that's a good option. But if a patient is having symptoms from edema, peritumoral edema associated with radiation necrosis, that like really makes me uncomfortable not getting surgery involved or talking about lit or something, because it's probably not going to get. It can be hard to just watch a patient take high dose steroids for 6 months and like not really get better, and then get all these problems from that. And so my approach is kind of to like make a bolder decision earlier on for the patient. If they're not operable, which they can be for many reasons, then that's okay. We're just going to go down this route instead. But
makes sense.
I have a low threshold to do a resection, and one of the reasons why is because you're making the assumption that you know it's radionecrosis, but I'll just tell you that you don't. Nobody does, and it is very the number of times that I've said this is for sure radionecrosis, and it ended up being active tumor, is embarrassingly high. But it's that way for everybody, you know.
I agree. Appreciate it.
This was fantastic, Dan. I really appreciate it. It was very super thorough, and it's going to be recorded on YouTube for everyone to watch. I really appreciate it. Hope to see everyone soon, and we'll see you guys in our next webinars. Thank you so much.
Sure. Thank you, guys. Have a great day.
Thank you.